Hello, everyone, and welcome to our Monday Night IBD video brunch series. Monday Night IBD is supported by educational grants from AbbVie, Janssen, and Takeda. I'm Dr. Aline Charabaty, the founder of Monday Night IBD. I'm the clinical director of the IBD Center at Johns Hopkins School of Medicine at Sibley Memorial Hospital in Washington, D.C. I am absolutely thrilled and very excited to be joined today by my colleague and very good friend, Dr. David Schwartzberg. He is an assistant professor of surgery at the IBD Center at New York Presbyterian, Columbia Medical Center in New York City. David, welcome to Monday Night IBD.
Thank you so much for having me. It's a real honor to be here, and I hope we can advance the education and kind of awareness of patients suffering with inflammatory bowel disease. So pleasure to be here.
Thank you for being here. I always appreciate your intervention when we're having the Monday Night IBD conversation on Twitter, and I'm very excited to have this video conversation with you today. Our faculty disclosures are on the screen. And in today's discussion, we're going to address all things related to J-pouch from a surgical standpoint. When do we proceed with a J-pouch? What does it mean to get a J-pouch? What do we expect to see on pouchoscopy? What is a good pouch function? What is a poor pouch function? And what does it mean to have a pouch failure and what to do next? Dr. Schwartzberg was kind enough to share his drawing talents with us. So as he's explaining these concepts, he'll also be drawing, a visual for us. So make sure you have access to audio and video for this discussion. So David, let's start with the basics. What is a J-pouch? When do we need it? And how is it built?
It's a great question. And I think even patients who've undergone the surgery sometimes have questions about that. So it's a very difficult procedure. It's got a lot of steps. It's important to understand kind of what goes into that. A J-pouch itself is a piece of small intestine that is folded on itself to essentially take the shape and function like a rectum would. For instance, here's the stomach and the small intestine, and it goes into the colon. When we do a J-pouch, we really remove everything from, including the appendix, which is something that I think people don't always know. We remove the entirety of the colon, all the way coming down, and remove the rectum. And then what we do is take this small intestine and refashion it. And the way it looks ends up being in the shape of a J. So zooming in, if this is someone's colon and it turns into their rectum, we actually have to remove the rectum itself and the colon. And then we make that J-pouch out of the small intestine, like this, and we bring that down to connect it to the anal canal. So where that rectum was is now the new J-pouch.
So David, you had a fantastic explanation. What is a J-pouch? We often talk about different stages when we're sending a patient for a J-pouch. Often a 2-stage or 3-stage, and I haven't seen a 1-stage in my career, honestly. But I would love for you to explain to us what is a 2-stage and what is a 3-stage, and how does it look? I think both patients and clinicians will find that very useful.
I agree. 1 stage can be done. 1 stage involves removing the entire colon and the rectum and making a J-pouch all at once. And there's some risk because it's not so easy all the time for this small intestine to reach down to the rectum. And a lot of times patients who are having these surgeries are having it because things are extremely inflamed. They're on medication, they're on biologics, they're on steroids. That's not the time to do these operations. And really, since so many patients are being treated, medically up front, I haven't really seen a 1-stage either. I will say a 1-stage. So again, a 1-stage is when you're doing everything at once. Colon's out, the rectum is out, and you're making your J-pouch. A 2-stage, typically done for patients who are doing well but are having problems with dysplasia. So what a 2-stage means is that your colon is coming out, the rectum is coming out, the small intestine is then made into a J and connected to the anal canal. And to let the J pouch heal, we're making an ileostomy bag here. And that's a 2-stage. So colon is out, rectum is out, the J pouch is being made, but we're doing a diverting loop ileostomy to essentially let all these connections that are on the J pouch heal before we reverse the ileostomy.
So the second stage will be reversing the ileostomy and allowing the stool to flow into the J pouch.
Exactly. That the ileostomy reversal is considered, a stage. One of the other things that people do is a modified 2-stage. So in a modified 2-stage is kind of like what a 3-stage is, which we're getting to, is when the colon is removed because the patient is toxic. The patient maybe is having bleeding. They're admitted to the hospital. They've tried, biologics. They've tried a lot and they're not doing that well. And so the colon is removed. The rectum, and this becomes the ileostomy, and the rectum stays in place. So the rectum is still there. The second stage is removing the rectum and making the small intestine into a J pouch, but no ileostomy. So that's a modified 2-stage. So modified 2-stage, colon is out, then you come back and take out the rectum and make the J pouch. What most people are doing these days is a 3-stage. So the 3-stage operation in many ways is the safest operation. And what that means is that first stage, the colon is out, the rectum stays in place. This allows the patient to nutritionally be optimized. They get weaned off of all their biologics, weaned off of all the steroids. And for about 6 months, the patient has an ileostomy and has the rectum. The second stage is when we remove the rectum, we turn the small intestine into a J pouch, and we give an ileostomy to allow all of the suture lines and staple lines of the J pouch to heal. So we come back, you take out the rectum, you do your J pouch, and you do a diverting loop ileostomy. The last step, once the gastrographin test is negative and shows the J pouch is healed, is to reverse the ileostomy. And then the patient, as you said before, is back in continuity, and the patient now has their J pouch hopefully function forever.
What I'd like to know from you is, how do you approach this discussion with a patient? Once you're discussing J pouch, what should the patient expect after surgery? What is considered a good functional outcome for a J pouch?
So the indications for J pouch, or the reasons we do it, have expanded. It traditionally was only for ulcerative colitis, but we've realized that you can also do it in patients with Crohn's disease. There's certainly a lifestyle change. Patients typically can expect around 6 to 7 bowel movements per day. Some patients have much less, some patients have more, and typically 1 bowel movement at night. I think the big issue that patients are very happy with their quality of life is they don't have the urgency that they typically had with the inflamed colon and rectum. And so that urgency is gone, despite having to go to the bathroom kind of more times a day than maybe a typical person would. That feeling of not having that urgency is a real big deal. And the success rate is really in the high 90s. But 95% of patients do very well with their J pouch. There are problems that can happen with the J pouch. As I said, it's a very complicated procedure. But luckily, basically 80% of those 5% can have a redo J pouch if need be. And so it's a very small percentage of patients who kind of don't do well with their J pouch.
That's a great explanation. And just for if we're having any people living with a J pouch or living with inflammatory bowel disease listening, just to clarify, when we talk about the absorption in the colon, we're mainly talking about fluid absorption, right? So all the absorption of nutrients happen in the small bowel. One of the colon role is to absorb fluid, and that is why when the colon is absent, we're having maybe more frequent bowel movement or looser bowel movement than when you have a full functioning and healthy colon. So that is why after J pouch, we are expecting 6 to 7 bowel movement per day, like you said, David, and maybe 1 or 2 at night. Do you see in your patient right after surgery more bowel movement and things get better with time? And what do you tell your patient? What do they, when should they expect that their bowel movement will normalize toward that 6 to 7 per day?
Yeah, I think the function can really vary, but it probably takes a year after their ileostomy is finally closed, let's say, and they have their pouch, it's working. It takes about a year to figure out how to fully empty the J pouch. I think that's one of the issues. If patients are not fully emptying, then it fills back up and they feel they have to go to the bathroom again. Typically, when the pouch fills up, it's when their brain says that they have to go to the bathroom, and they go to the bathroom and they empty their pouch. Now, the amount of time it takes for the pouch to fill up again is how much time it is between bowel movements. One of the things that can happen, especially if the stool is too thick, is that when the pouch is full, the patient goes to the bathroom, but only half of it empties. So it's not that much more time until it fills up again. So in someone who's having trouble emptying their pouch, there can be a narrowing here. That's called a stricture. There can be a slight twist in the pouch, which prevents it from eliminating. But at the same time, sometimes patients who are having frequent bowel movements, the best thing to do is take some Miralax. Even though it doesn't sound like it makes any sense, what the Miralax will do is help the patient empty their pouch entirely. And that way, it's going to be a longer period of time before their pouch fills up and the patient has to go to the bathroom. So sometimes the feeling of going to the bathroom multiple times, people think, oh, I better take Imodium, thicken the stool up to help me not go to the bathroom so frequently. But actually, the thick stool prevents it from fully emptying, and then it empties back up even quicker, and then they have to go to the bathroom even more. So there's a lot of kind of figuring out how the pouch is going to work. There's also really, it empties by gravity. It doesn't really have contraction like the colon or the rectum does. So there's certainly some getting used to of the pouch. But again, the success rate and the quality of life that's reported by the patients is almost 100% that they're happy with this procedure.
I agree. Most of my patients who required a J pouch tell me, I wish I had this done before. Usually these are people with poorly controlled ulcerative colitis and having a poor quality of life before surgery. But this is very important conversation to understand the expectation for patient to understand when to expect that full J pouch function, and for also gastroenterologists to understand that it may take time, and it just patience and time, and maybe doing few dietary changes or support the patient in their journey to getting a full J pouch function. Shifting gear to gastroenterologists, when we as gastroenterologists are doing a pouch exam, an endoscopic pouch exam, what are the landmarks to identify when we are scoping?
So when doing a pouchoscopy, there's a few things kind of pay attention to. And they're important because if someone has abnormalities of these, then we can figure out if there's something wrong. Now, one of the first things is when you put that scope in, what you want to see is the anastomosis. Now, a patient could have a hand-sewn anastomosis, so the pouch would be very close to the anal canal, and you won't be able to feel any kind of circular staples. But one of the things you kind of want to look out for is if you put that scope in, and this anastomosis connected to the J pouch is all the way up here, that might mean there's retained rectum. And so if the patient's having difficulties with bowel function, they could have a narrowing here. And the reason they have that narrowing is that there's rectum that's been left in place. And we see that this does happen. So the patient still has ulcerative proctitis. So it's important to know when you put that scope in during a pouchoscopy, first thing you want to see is the anastomosis, which is here and should be open. The second thing, when you're into the pouch body now, is if you're looking from this direction, and here's the scope, what you want to see is the staple line right on the bottom and the staple line right at the top. And these staple lines should be straight. You want to see on one side the tip of the J with a transverse staple line, and on the other side another hole, and we call this the owl eye. And in there is the bowel that's proximal to the pouch. I think it's important to be able to identify that these staple lines should be straight, and it should lead to the owl eye, and that any deviation where these staple lines are started to get twisted could mean that the patient has a pouch twist, especially when you're looking at the lumens in the wrong orientation. Now, if the patient has a partial twist and they're feeling otherwise all right, I'd leave it alone. But if the patient's having trouble emptying, they're having chronic signs of pouch failure, chronic pouchitis, lower abdominal pain, then that's certainly, a place that we should look. So that's looking at the anastomosis, and that's looking at the staple lines that actually form the pouch. Now, sometimes along those staple lines, there can be little ulcers. That can be from ischemia. They can be biopsy, but it doesn't necessarily mean there's something wrong. The other thing you want to take a look at is the tip of the J, which should be sealed. If you notice there's any kind of defect and the patient's having abdominal pain, that could be an evidence that the patient actually has a tip of the J leak. And that's something that is very sinister, that it appears very slowly over time, but typically causes a lot of issues and a lot of inflammation in the pelvis. The last thing is, after you go to the tip of the J, you want to go to the proximal bowel. And so you want to be able to enter the proximal bowel straight. If there's some reason that you can't get higher up in the bowel, it could be that there's what's called afferent limb syndrome. And it means if you're looking from the side, if here's the sacrum, and here's the pouch connected to the anal canal, it could mean that there's a loop of bowel stuck between the pouch and the sacrum. And sometimes that also causes ongoing obstructive symptoms that are very difficult to diagnose. So in summary, making sure there's a low connection, that there's no retained rectum, making sure that the staple lines are nice and straight, making sure the tip of the J is intact, and making sure you can enter the proximal bowel with the pouchoscopy, and looking for ulcers both in the pouch but also in the pre-pouch ileum.
What does it mean to have a pouch failure? What does it mean in terms of symptom, in terms of prognosis, in terms of what would come next for the patient?
So there's really two different kind of groups of patients who may have issues after a J pouch. So the majority of patients are doing very well, but there's kind of two groups of patients that end up kind of needing some intervention. Maybe it's antibiotics, maybe it's intervention with dilations, with endoscopy, maybe it's actually, repeat operations for pouch augmentation or to fix the pouch or redo the pouch. And one of the groups of patients is patients who are doing very well for a long time. And a lot of those patients, they were doing very well, had excellent pouch function, and then 10, 15 years later, all of a sudden, they're starting to have issues. Sometimes we think that might be a sign that the patient does have Crohn's disease after all. And it's not that they need their pouch to be excised, but it certainly means that we need to make sure that it can be treated with medicines appropriately and to figure out what's going on. And that really takes a lot of conversations between the patient, the gastroenterologist, and then also the surgeon. The other group of patients is patients that had a J pouch and then maybe immediately after surgery had some issue. Maybe there was a bleed, maybe there was a leak, maybe there was some kind of bowel obstruction. And these patients they always say is they never really felt right after surgery. If these patients are presenting with frequent bowel movements or signs of obstruction, the opposite, abdominal pain, maybe weight loss, chronic pouchitis, which is a lot of pelvic pressure and sometimes even blood in the stool, that's a sign, especially within the first year, that there might be something mechanical or technical. We haven't even talked about the infectious kind of complications. We're talking a little bit about an anatomy things such as, is there a twist? Did someone leave rectum there? But if this is the sacrum, this is the bone. And if this is the pouch, which comes in here, there's also a lot of things that can cause septic complications. So if there happens to be a leak at the anastomosis, which is right here, if there's a leak, this leak can go to the presacral space and it can cause a chronic abscess. Now, sometimes we can open up that space and essentially make that abscess part of the pouch, and we can save the pouch that way. The problem is sometimes if you're looking at kind of the anus from this direction, any abscess in this area can drain multiple ways. And so what you'll see is abscess, fistulas, could be multiple tracts, could look very complex. And what happens when there's abscess and fistulas around the anus? People immediately start saying, oh, the patient must have Crohn's disease. But it might not be Crohn's disease. It might be because there's an abscess that was draining, and it drains through the skin because of gravity. The real problem is, especially in a woman, if this is the vagina, it can drain anterior, which is towards the vagina, and the patient can have a pouch vaginal fistula. The other thing that can happen is these chronic fistula tracts, which again look very suspicious to Crohn's disease, but the cause of it was that the anastomosis, which is the connection between the anal canal and the pouch, had a leak.
So if we see those fistula or these abscesses early after surgery, within 6 months of surgery, we have to think about a leak. These complications happening later, then we should think about potentially this is being Crohn's disease. Is that correct?
Absolutely. And that's kind of the infectious abscess fistula component. The other component, as I mentioned before, is if someone has rectum that's in place and their J pouch is connected, to that rectum, and this rectum is still in place, what happens is it gets very inflamed. And this inflammation ends up causing the connection to be inflamed. And so what happens is it gets narrowed. So patients all of a sudden, a few months after surgery, who constantly need to have an endoscopy or need to have their stricture opened, people say, oh, stricture must mean Crohn's disease. Well, sure, stricture could mean Crohn's disease, but as you said, the timing is so important because it might not be that this connection is getting narrowed because of Crohn's disease, but it's getting narrowed simply because it's right next door to this rectum that's still inflamed, and that inflammation is causing this narrowing. So that's something else that can mimic Crohn's disease, but is actually a technical, mechanical consideration that we can correct, because what we can do is, and this is part of the redo pouch process, but move this pouch out of the way, fully dissect the rectum, make a new connection. And now that that rectum is gone, we can then bring this pouch down and make a new connection. And so that's someone who has retained rectum. That's how their redo pouch surgery goes.
So when we see a stricture high up in the pre-pouch ileum, what does it mean? Is it clinically significant? Can this be causing symptoms in our patients with a J pouch?
As soon as someone has a J pouch, any problem, everyone says, well, it's the pouch. It's got to be the pouch's fault. Someone has a J pouch and they can't go to the bathroom, or they're having abdominal pain. It's got to be the pouch. But the truth is, there's, things that can go on above the pouch. One of them is afferent loop syndrome, which we discussed, which is where there's a loop of intestine that's kind of caught behind the bowel, and it's causing an inability to go to the bathroom. But the other thing that we see kind of much more common, in my opinion, is right above the pouch, there's an ileostomy that was here that was closed. Now, the way, I close it is hand sewn. So the bowel looks like that. So when that ileostomy is closed, it's nice and straight. The problem is a lot of people close it stapled. And what happens when it's stapled is the bowel kind of gets placed in this orientation. And the staple line is here. And so what happens is this staple line, it's not very anatomic. It's not like the God-given anatomy that would be in a straight line. It's kinked. And so what happens, sometimes the food or the stool has trouble kind of getting through. So what happens is this area gets more and more dilated and more dilated. And it gets so dilated that it basically is an obstruction, but it doesn't look like an obstruction on the CAT scan. It looks like everything's open. In fact, it looks too open. So one of the things that I think is important, if someone's having signs of abdominal pain with a pouch, it's important to look up here. It's important to look above the pouch. And one of those things could be the ileostomy site. So when you're doing a pouchoscopy and you looked at your tip of the J and you go look at your pre-pouch ileum, and it looks like there's a stricture 10, 15, 20 centimeters proximal to that pouch inlet, which is right here. You have to think, is there some kind of anatomy that's been distorted because of the ileostomy closure? And that could be the issue. So sometimes resecting this area and putting it in this configuration can solve the problem.
So we talked about the pouch failure, and if the patient needs a redo of their pouch or an ileostomy, how do you decide which patient would need one or the other? And if the patient gets a redo pouch, what can we expect in terms of pouch function and quality of life?
No, that's, I think, the most important point, that the whole field of redo pouch surgery is driven by the patient. And if the patient is happy and comfortable and will have an excellent life with an ileostomy, then it is a disservice to convince them to have a redo pouch. Vice versa is also true, that if a patient does not want an ileostomy, they should be given the opportunity to have a redo pouch. And this is something that, my mentor, Dr. Feza Remzi, always talks about. This is patient-driven. And there are patients who will do fine with an ileostomy, but there are patients who don't want a permanent ileostomy. They want to have a shot at that redo pouch, and we can do that. There are some things to consider, that a redo pouch surgery is typically a 3-stage pouch surgery all over again. There are some things like maybe a tip of the J pouch leak or some other things that we can do, like a sinusotomy if someone has a presacral collection. There are these kind of things that you can talk about in more detail with your local, gastroenterologist or IBD surgeon. But for the most part, to redo a pouch, patients get an ileostomy beforehand. They have that for a few months to mentally and physically get ready for what's a major operation, which is to kind of remove that old pouch, fix what's wrong, either put that pouch back or make a new pouch, and then have an ileostomy to let everything heal, and then finally reverse the ileostomy. So it's kind of like starting from scratch. But in a motivated patient, it certainly can be done, and it can be done safely. But this whole act of redoing pouches is very specialized, and it's not everywhere. And the patients, in some ways, have to seek out where to go. The benefits and the successes are much higher at these high volume centers, because it does have to be, it's very humbling, as you said, to go back into someone's pelvis. There's a lot of nerves, a lot of blood vessels, a lot of things. You have to be very careful. These are cases you take your time on. You want your surgical team. You want to have people who are taking care of the patient with you afterwards, to everyone be on board. And so I just implore the patients to seek second opinions, to figure out, what's right for you. And it's important to have a relationship with the surgeon. That is someone you have to be comfortable with.
Well, thank you, David. Thank you for being here. Thank you for these fantastic drawings that make these concepts easier to understand. And thank you for everyone for joining us today. Please make sure you claim your CME credits by completing the post test and the evaluation form linked below, or by following the QR code shown on the screen. Thank you, everyone.